He also denies having any symptoms when he swims. His meds include aspirin, lisinopril, and metformin. He smokes half a pack a day, drinks a couple beers a week. And on exam, he's normal tensive. And the rest of his exam is benign. In regards to labs, he has normal renal function. He has a normal BNP. So this is his baseline EKG. Let's take a look at that for a second. And this is unchanged from the past. So what is the most appropriate study to order to further evaluate this patient's chest pain? A, an exercise treadmill stress test. B, a coronary angiogram. C, a coronary calcium score. D, a coronary CT angiogram. Or E, provide reassurance. What is the most appropriate study to order to further evaluate his chest pain? Give you a few seconds. I can't actually see the polls.
You will be able to in a moment. You should
Okay.
be able to see it now.
Yeah, maybe I need to just change my settings a little bit. So let's just go over this question. Yeah, I can't really see. Let me see if I decrease my screen.
Under the for Zoom, wherever your list of options are, like share, next to it there should be a triple dot, and under there there's polls and quizzes,
The
and you
problem is
uh
I'm seeing the whole, I'm seeing the whole slides, and I'm not seeing you guys, but that's okay. Um, Let me go back there. Display, swap.
if it's helpful, I can read you the results for
Yeah.
each question.
So let's just talk about the results, and let's talk about the question. So I think what's important in patients with a stable CAD, um, to determine if you need further risk stratification, you really have to think about their pretest probability. So if their pretest probability is in that intermediate range, then it's useful to consider further risk stratification. If a patient has a very low pretest probability, then you really don't need to do anything and you can just kind of monitor. And if they have a very high pretest probability for obstructive CAD, then you kind of already know what you need to do. You either need to treat them for angina if they're having symptoms, or you can consider revascularization. In this patient, his pretest probability lies in that intermediate range. He's having a pretty decent story for angina, but it's not always predictable. So there's some question, is this actually due to obstructive CAD? And then your question is, what are your options? So you have a lot of options when you're ordering further testing for risk stratification. You could order just a plain old treadmill stress test. You could do a MPS, either with exercise or with regadenoson, so a pharmacologic MPS. You could order an exercise stress echo or a dobutamine stress echo. You could consider a CT PET stress test, or you could order a coronary CT angiogram, a non-invasive way to define this patient's coronary anatomy. If you look at the sensitivity and specificity of these tests, this plain old treadmill stress test is actually the least sensitive and the least specific. So in general, we don't recommend this test unless they're kind of in that low intermediate pretest probability. And obviously they need to be able to exercise and have an EKG that's predictable or interpretable. The stress echo and the MPS are pretty similar in sensitivity and specificity. And the coronary CTA is very sensitive and has pretty decent specificity. The CT PET is also a really good test with good sensitivity and specificity, but it tends to be quite expensive and sometimes not covered by insurance companies. So in trying to figure out what the best test is, there's going to be something in the stem of the question that leads you to the right answer. So, in regards to this patient, you're worried that he's having angina, that he's having ischemia causing these symptoms. So, further risk stratification seems reasonable. And then you have to ask yourself, can this patient exercise? And from the stem, he seems pretty active. He's swimming, he's walking, he's pretty active. So the answer here would be yes. If it was no, then you would ask yourself, does this patient have ischemic heart disease? If he has known ischemic heart disease and he can't exercise, a coronary CTA is not your best answer. We don't recommend ordering a CTA for patients with already known coronary artery disease. But you could order a pharmacologic MPS or a pharmacologic echo. In this case, the patient can exercise. And so the next question is, does he have an EKG that is interpretable? And he has a left bundle branch block. If you recall, that EKG showed a left bundle. So a standard exercise EKG is not an option. Moreover, his symptoms or concerns were more in that intermediate range. So a treadmill stress test would probably not be the best test anyways. So since he doesn't have an interpretable EKG, the best answer is an exercise MPS or a exercise treadmill stress test, echo, exercise, basically an exercise treadmill echo, or you could order a coronary CTA. And if you look back at the answer choices, an exercise stress echo and exercise MPS aren't options. So the best answer here is a coronary CT angiogram. So you order a coronary CT angiogram and you find that the left main is normal. The LAD has minimal stenosis. The left circumflex has moderate stenosis defined as 50 to 69%. But the most concerning thing is this mid RCA stenosis that's defined as 70 to 99%. Get an echo, which shows a normal EF and no valve abnormalities. So the next question, patient is reevaluated after his coronary CTA findings. His symptoms are unchanged. Based on current guidelines, you recommend the following immediate intervention. A, proceed with PCI to both the RCA and circ-OM lesions. Proceed with a two-vessel CABG. Optimize medical therapy. Refer for a pharmacologic MPS, or order an exercise stress echo. What would be the best immediate intervention? Again, I can't really see the pulse, so I'm not really sure.
So it looks like it's primarily between A and C with a few choices for E.
Okay. So let's talk a little bit about this question. We'll get back to it in a second. But what I really want to touch base here is when should you consider revascularization for chronic coronary syndrome? And when you think about revascularization, we always ask ourselves, why are we doing it? So we do it for two reasons. Either we're going to improve survival or major adverse cardiovascular events, or we're going to improve symptoms. And so when does revascularization for stable ischemic heart disease improve survival? It improves survival when the EF is less than 35% with multivessel disease. And this is based on a randomized controlled trial called STITCH or STITCH Extended. And this was a study that looked at patients with multivessel disease with a low EF, less than 35%, and they randomized them to either CABG or medical therapy. And in that situation, it did show that CABG improved mortality. Interestingly, PCI, they did a similar study looking at PCI versus medical therapy in the same patient population, and it didn't actually improve mortality. The other situation where revascularization improves mortality is left main disease, either by PCI or CABG. So the other reason we revascularize patients for stable ischemic heart disease is to improve symptoms. And it's recommended to do revascularization if they have refractory angina despite medical therapy or are intolerant or resistant to medical therapy. So this is just kind of rehashing the guidelines again. There's a class 1 indication to revascularize a patient if they have a low EF and multivessel disease. And really, the recommendation is CABG. Or if they're having angina that's life limiting despite being on goal directed medical therapy. So your medical therapies to improve angina medically is first-line beta blockers, calcium channel blockers, or long-acting nitrates such as isosorbide mononitrate. A second-line medicine that you could use is ranolazine. And generally, we recommend patients being on at least 2 antianginals before considering revascularization. So in this patient, the correct answer is C. He's not on any antianginals. He hasn't been optimized with medical therapy yet. So we would recommend trying medical therapy first. And if they're continuing to have symptoms, then you can consider revascularization via PCI. So